minute wait and we'll begin to read. Be ready. I ask you to read the KROK test. Yes, I prepare for you KROK. We need to finish KROK devoted to bleedings and KROK devoted to trauma, birth trauma, and anomalies of labor activity. And no, I don't know if it will be the time KROK fresh of 18th year. I want to show you. Now, let's begin, guys. And I ask you to read. Today there is no topic. I promise you to speak about the KROK test. Yes. And Suresh, I don't see Suresh. Now he's absent. That's why, Preeti, read the test.
Yes, teacher.
Mm-hmm.
A 25-year-old female patient complains about having amenorrhea for 3 years. She associates it with difficult labor complicated by massive hemorrhage. She also complains loss of weight, hair fragility and loss, lack of appetite and depression. Objective examination reveals no pathological changes of uterus and its appendages. What disease pathogenesis? Teacher, it is hypoproduction of gonadotropin.
Yes. Why we have this hyperproduction? What disease they mean when they describe the condition?
This one is Sheehan syndrome.
Shehan, you are quite right. Yes, you see variants of answers. Yes, maybe they suggested you pathogenesis, hyperproduction of gonadotropins. Sometimes they suggested you analysis. Yes, check of these gonadotropins, or suggested you to set the diagnosis of Shehan. Yes, maybe different variants of, but you take in account that massive bleeding in labor. First of all, you think about the Shehan and decrease the level of gonadotropins. Yes. I see that Suresh appear. Suresh, can you read the next test, number 23? Suresh.
Yes.
Mm-hmm.
Ambulance delivered a 21-year-old woman to the gynecology department with complaints of bulky abdominal pain and bloody discharge from the genital tract. Bimanual examination revealed that uterus was soft, enlarged the size of the gestation. The gestational sac was palpated in the cervical canal. Uterine appendages weren't palpable. Fornips are free, deep, and painless. Discharge from the genital tract are bloody and profuse. What is the most likely diagnosis? The abortion in progress.
Yes, give me argumentation why it is abortion in progress, why it is not threatened abortion, incipient abortion, or cervical pregnancy.
Okay.
Or
it's abortion in progress because there is the genital sac is palpated already in the cervical canal.
Yes, and this enough not fill the mind with other situations. Yes, if cervical sac in the cervical canal, of course it is abortion and present bloody discharges. Yes,
Yes.
Thank you. Please, the next Salim Yasmin. Yamin.
A pregnant woman was delivered to gynecological unit with complaints of pain in the lower abdomen, insignificant bloody discharges from the genital tract for 3 hours. Last menstruation was 3 months ago. Vaginal.
I don't hear you. Yamin, I don't hear you.
Hear me now?
Vaginal examination show that the body of the womb, yes? Read please, if you hear me.
A fingertip could be inserted into the external orifice of uterus. Bloody discharges was insignificant. USI showed small vesicles in the uterine cavity. What is the most likely diagnosis? It's a grape mole. Because
Yes.
the ultrasound shows small vesicles. It's a molar pregnancy.
And this is the keyword, guys. When you know, maybe you know this tactic, yes. You usually students like to remember the keywords, yes. But maybe other tests. No, I will tell you the example when we need to know more, yes. But here, of course, vesicles in the uterine cavity, and it is the grape mole, yes. No other condition among these options, which gives us this clinical picture. Then next, please, number 9. Nidhi. What? Again, repeat. Check what? Chat. No, now everything, in my chat is everything all right. Сейчас, подожди. But what question you have? KROK question. What question, please? Can you tell me? Can you read me this KROK? Uh-huh. 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 And options. But what about uterus? Can you read again the changes on the side of the uterus? Mm-hmm. Mm-hmm. And that's all? And what about cervix? And right answer, it is inevitable abortion, yeah? No, I don't know where you take this test. From what year this test? No, at all we cannot say exactly. Blood discharges, yes? Feature alive or not? And right answer, inevitable abortion, yes? No, my dear, it cannot be inevitable abortion. It's maybe only threatened abortion, but maybe it is wrong answer. It is the question from the, no, I hope that such question will be absent in a new KROK test. Maybe it is old question, I don't know. Uterus increase in size correspond to the age of pregnancy and mild bloody discharges. It's maybe incipient abortion. Or right answer, incipient abortion, my dear. What is the right answer? Inevitable or incipient? No, my dear. No, uterus. And what was the delay of menstruation? No, it is correspond to the or to her age of pregnancy. No, here maybe incipient abortion because mild bloody discharges. No, it is. I told you that I don't like this question sometimes because they did not give us enough information to make our conclusion. Guys, you need to remember if you meet this question. No, maybe these mistakes, but clinical picture is not correspond to the inevitable abortion. Inevitable should be open cervix, should be profuse bleeding. Only in this case we can state the diagnosis of inevitable, but at all it's not enough information in this question. I cannot. Guys, number need here, please read me the test number 25.
A 28-year-old female patient complains of having hemorrhage from genital tract for 1 month. 6 months ago, she had natural delivery and gave birth. Ma'am, is the question, ma'am, I can't see the question properly, completely. Oh, I can see. Uh, uh, 6 months ago, she had natural delivery and gave birth to a girl weighing 3,100 gram. Objectively, the uterus is enlarged to 9 to 10 weeks, mobile, painless, of heterogeneous consistency. Examination reveals vaginal cyanosis, anemia, and body temperature rise up to 37.8 degrees centigrade. There is a significant increase in HCG concentration in the urine. What is your provisional diagnosis?
Diagnosis, yes. And they give you malar pregnancy, hydrogen mole, endometritis, and uterine chorioepithelioma. Uterine, I don't know what they need to write here. Yes, uterine chorioepithelioma. Yes, uterine chorioepithelioma. It is the right answer. Yes.
Yes.
What are the signs? Why it is not hydrogen mole? Very confused question, guys. But what we have, malar pregnancy, usually we determine in early pregnancy, yes? Partial malar pregnancy, partial hydrogen mole. We cannot sometimes recognize the tool, yes? 1% of labor will be with partial malar pregnancy when woman gave birth with a healthy fetus, and maybe some vesicles change in placenta, and 1% of this disease pass spontaneously go, yes, but sometimes maybe complication. Yes, if it is guided to deform mole, they give you at once the clinical picture, vesicles in the uterus, absence of the feature. If you have this test when the woman gave birth and some time later, yes, 6 months ago she have the birth, appear enlargement of the uterus, yes, heterogeneous consistencies, but what are the main in this test, which show us that it is uterine chorioepithelioma? Chorioepithelioma, guys, it is complication of hydrogen mole of malar pregnancy. If it is malar, they give you at once clinical picture. I told you again, vesicles, yes. If complications appear sometime later, and what are the main, guys? Here keyword, it is significant increase in chorionic gonadotropin level. If complication occur some months after labor, usually it is malignancy. It's maybe uterine chorioepithelioma or maybe uterine choriocarcinoma. All two these diseases gives us increase the level of chorionic gonadotropin. Yes. And no body temperature rise due to the influence of hormones, yes, but first of all it is the level of chorionic gonadotropin and increase in size of the uterus. It shows that something wrong with the uterus after labor. And what's wrong? We have high level of chorionic gonadotropin. It is the reason, it is the sign of chorioepithelioma, guys. Not so easy test, yes. Because present also hydrogen mole, but mole it is during pregnancy or just after labor. If we have some time later, we have 6 months, it is appearance of trophoblastic. It is one of the part of trophoblastic disease. I told you chorioepithelioma. Clear for you guys?
Yes.
Guys, you hear me?
Yes.
Yes, teacher.
Yes.
Yes, remember about it. Yes, I want to tell that at all, if it is partial mole, very rare, 1% of labor, but may be present, guys. And usually the woman without any further complications, but sometimes pass. But sometimes appear these conditions as chorioepithelioma. Так, the next. Who the next? Так. Natalia, yeah? Eutemia, please read the test.
Okay, ma'am.
Mhm.
A 10-week pregnant woman was admitted to a hospital for recurrent pain in the lower abdomen. Bloody discharges from the genital tracts. The problem stand up after ARPI. The woman was registered for antenatal care. Speculum examination revealed cyanosis of vaginal mucosa, clean cervix, open cervical canal discharging blood and blood clots. The lower pole of the gestational sac was visible. What tactics should be chosen? Curettage of the uterus.
To my mind, we have this test when we have the topic miscarriages. Yes, what we have here? It is inevitable abortion or abortion in progress. Yes, because we
Yes,
see the lower pole of gestational sac, and only which we can do, we need to stop the bleeding and as soon as possible to perform curettage of the uterus. We cannot maintain the pregnancy. We cannot wait because profuse bleeding. Hysterectomy is so strong for the young woman and no indications, and antiviral therapy cannot help us in this case. Yes. Thank you. Mahanti, please, number 27. What kind of abortion, my dear? What kind? What diagnosis you can set? Cervical canal, let a finger and fetal tissues palpated in orifice. They mean in ostium of the uterus, yes? Cervical os, orifice, in this case, it is cervical os. It is what kind of abortion?
Incipient.
Guys, why incipient, my dears?
Oh,
Canal open and tissues in the cervix, in the orifice, in the cervix. It is what?
inevitable.
Yes, inevitable or abortion in progress. You are quite right, yes. And that's why it is instrumental extraction of that fetal tissues, guys. You see, they change sometimes. Maybe curettage of the uterus, but it's the same as instrumental as extraction of the fetal tissues. Maybe such option, but it is the same. And more better to say curettage of the uterus, yes. Then 28. 28. Milimba present, guys. Absent, yes. Milimba absent. Now, Mandeep Singh, read please the test.
A 36-year-old female presented to the gynecologist hospital with a significant bleeding from the genital tract and a 1-month delay of menstruation. By manual examination reveals soft barrel-shaped cervix. Uterus was of normal size, somewhat softened. Appendages were unremarkable on the both sides. Speculum examination reveals that the cervix was cyanotic, enlarged, with the external orifice disclosed up to 0.5 centimeter. Urine HCG test was positive. What is the most likely diagnosis? It's cervical pregnancy because this the barrel-shaped cervix and
Yeah.
HCG test was positive. So it's
Yes,
present
they,
in the
yes, you are quite right. Yes, thank you. And we have delay of menstruation. Yes, usually it is specific for pregnancy, but barrel-shaped cervix, cyanotic pelvis. You saw, do you remember I showed you a picture of the cervical pregnancy? Yes, that cannot be threatened miscarriage. It is, but what is the provoke in these options, guys? Cervical pregnancy, it is also ectopic. You see here the option, ectopic pregnancy. But more exactly, if they give you the clinic, yes, barrel-shaped cervix, RFIs disclose, yes, urine test positive, more better to choose cervical pregnancy. Ectopic also, no, in general, it is right answer, but it is maybe as provocation. That's why cervical pregnancy. You are quite right. You told me that first of all, it is barrel-shaped pelvis, cyanotic, also it is specific for pregnancy, yes, and of course, plus delay of menstruation, plus the level of chorionic gonadotropin. Number 29, thank you. It was Mandeep Singh. Now, Khan, please read the test.
30-year-old Persuasion patient was delivered to maternity hospital with full-term pregnancy. She complains of severe lacinating pain in uterus that started 1 hour ago, nausea, vomiting, cold sweats, unnecessitated cesarean section 2 years ago. Uterine contractions stop, skin and mucous membrane are pale. Rate 100 per minute, blood pressure 90/60. Uterus has no clear margins, is sharply painful. No heartbeat can be auscultated in fetus. Moderate bloody discharge from uterus can be observed. Uterus cervix is 4 cm open, presenting part is not visible. Uterine rupture.
Yes, what, no, here we have here initial uterine rupture. They mean maybe rupture which begin threatened uterine rupture, premature detachment, and compression of the inferior pudendal vein. Yes, it is vena cava syndrome, we name this, guys. When the woman lost consciousness, when she changed the position and lie on the back, woman lost consciousness usually due to the pressing of the no, inferior pudendal vein. It's not right. Vena cava.
Yes.
Guys, what signs of uterine rupture here in test?
Contractions stops there.
Yes. What else? Stopped contractions. Yes. Signs. It is yes. Contraction stops. Usually we think about rupture and no what? Fetal heart beating. Yes.
No heartbeat and there's a sharp pain.
Sharp pain, and in the history, to my mind, she has the pain
already
in the
uterine section, cesarean section.
yes, it was in the history was cesarean. Also, it's maybe uterine rupture. It is a lot of here in this test, a lot of signs of uterine rupture, signs of hemorrhagic shock. You see BP and heart rate, yet blood discharges. Is not visible present in part because all feature in the abdomen cavity. Yes, in the history it's cesarean, of course. First of all, it cannot be initial rupture. Initial maybe bleeding, and maybe signs wrong shape. Usually they don't give you this in KROK test. We have question threatened rupture and uterine rupture in most of cases. Так, and now other topic which we have no time. Yesterday was bad internet. Yes, to speak about the topic devoted to test, devoted to Khan. Yes, read the test now. For Shanil present, Kaushal. He is not here, absent, yes, and that's why for Navjot Singh question, read please. The first question devoted to the abnormalities of the uterine activity. Guys, we have 9 minutes, then we'll meet with you at 9:50. Now we have 10 minutes. 9:50. Again, we speak about the KROK test. Navjot, please read.
Yes, a 37-year-old Premi-gravida woman has been having labor activity for 10 hours. Labor pain lasts 20 to 25 seconds every 6 to 7 minutes. The fetus lie in longitudinal and the presentation is cephalic. Head is pressed upon the entrance of small pelvis. General examination results cervix of uterus is up to 1 centimeter long. Let's two transverse finger in and fetal bladder is absent. What is the most probable diagnosis? There is primary uterine inertia.
They give you here all options, guys. Primary uterine inertia, secondary uterine inertia, normal labor activity, discoordinated labor, and pathological preliminary period. Yes. Why this is primary? They can give you the same test with secondary uterine inertia, for example. Why it is primary uterine inertia?
In primary, there we can see that failure of myometrium to establish a contraction.
You don't look in the base of the problem, my dear. I don't know how to explain. You don't, when you solve this test, you don't think about the pathogenesis of this condition. First of all, if it is primary inertia, you need to know this. That's why I pay your attention. We begin yesterday classes and I step by step explain you primary uterine inertia from the very beginning of labor activity. You need to know the development of labor activity. And you know the first stage, it is latent, first of all, phase, yes, 8 hours, cervix need to be effaced and open to 3-4 centimeters. Here we have even know after 10 hours of labor activity, you see, we have no even all effacement of the cervix, the length of the cervix 1 centimeter, not complete effacement, led only to transverse fingers, and 10 hours pass. But pay attention to the prolongation of these contractions, only 20-25 seconds, and interval also very very large, 6-7 minutes. At the end of the first stage of labor, it is only 1 minute interval and 1 minute prolongation of the contractions. Yes, and after fetal bladder is absent and head pressed to the entrance of the small pelvis. Don't engage after 10 hours of labor activity. And
what is this fetal bladder is absent? I don't understand this one.
Fetal what? Fetal bladder. My dears, it's of course you cannot understand because it is amniotic sac is absent. It means that amniotic fluid escape, yes, outflow. It was happened outflow of amniotic fluid, and if there is no amniotic fluid, amniotic sac is not palpable. Yes, membranes we cannot palpable with the help of our fingers. Amniotic fetal blood, it's not fetal blood, it is amniotic sac, guys. Of course, your right name, it is amniotic sac. Amniotic, they want to say you that amniotic fluid was escaped. Yes, it happened in the first stage of labor. But what's abnormal here? It is latent phase more prolonged, 10 hours, but we have no even effacement of the cervix. At the very beginning, very short prolongation of the contractions, prolonged intervals, this characterize the primary uterine inertia. Secondary, usually they describe some period of good labor, normal labor activity. You know how characteristics of normal labor, discoordinated labor. When uterus contracted, very painful contractions, but on the we have the test on the height of paradynia. Paradynia, it is contractions of the uterus. On the height of these contractions, the cervix, the doctor feel that cervix not relax, but begin the spasm of the cervix. Yes, contracted cervix. It is usually they describe in this way the discoordinated labor. There is no productive labor, no dilation of the cervix, only spasm or contraction of the cervix during contractions of the uterus. Yes, if it is normal labor, uterus contracted and cervix relaxed. If it is discoordinated labor, uterus contracted and cervix also contracted, not relaxed, no relaxation. And pathological preliminary period, guys, it is the period maybe you know, before labor, when uterus prepare for labor, organism of the pregnant woman prepare on pregnancy, membrane formed dominanta of labor, and appear the first irregular contractions. These irregular contractions can occur in different intervals, prolongation may be different, but women suffer from these contractions because she cannot sleep, she feels the pain, she exhausted, and if this period prolonged more than 4 hours, we name this pathological preliminary period, and in most of cases it finishes with cesarean. Guys, the next, thank you for Navjot and Thunia. Yes, have read the test, and when they begin again, we have 3 minutes. We will, Thunia, it is your last KROK, and then we make the break, guys. Read the test, please.
A 30-year-old gravida woman has intensive labor pains every 1 to 2 minutes that lasted 50 seconds. Disengagement has started. Perineum with height 4 centimeter has grown pale. What actions are necessary in this situation? The answer is episiotomy.
Can you explain me what does it mean, episiotomy?
It's like an incision is made below the vaginal opening.
No, below, on the left or right side, yes? On the left or right side from the perineum, yes?
Yes.
Guys, what's wrong we have here?
The perineum has grown pale.
Grown pale, it is what? The sign of risk of the rupture of the perineum, yes? Then, guys, why the feature can be born? Because in this case, perineum become obstacle for labor. Feature can be on the bottom of the pelvis, yes, on the pelvic floor, but on the pelvic floor. But this height perineum, it is 4 centimeters and more than 4. It is, we name this high perineum, become the obstacle for further birth of the fetus head. Yes, and if we have perineum more than 4 centimeters, it is indication for section of the perineum, but we don't make perineotomy in the middle of perineum, but we'll speak about it. We have obstetric operations topic, and I will tell you when we need to perform episiotomy, when we need to perform perineotomy or expected management. Yes, guys, episiotomy, we make the incision on the left or right side from the peritoneum. We have signs of risk of the rupture of perineum because perineum is very high. In any case, we need to make the section, because in this case, it is obstacle for birth of the fetus head. Yes. Then, if we have the perineum begin, we have beginning of the rupture of perineum, appear blood, yes, it's a rupture of perineum, to artificial, and we perform perineotomy because healing of the wound with incision more better than healing of spontaneous wounds after labor. Yes, but in this case, what is Remember, indications for episiotomy. Yes, and we have, you are quite right. Right, the signs of threatened ruptured perineum. Guys, now we